So here is the diabetic mogul. I'm honored to have these special guests, and I'll allow her to introduce herself to the audience. Please take it away.
Oh, shall I introduce myself?
Yes.
Okay, so hello, my name is Gajewska. I'm a psychologist by background. I'm a diabetes educator. I'm a researcher, and I'm a person living with diabetes for the last 35 years, so almost my whole life. And I work with Diabetes Ireland now, live in Ireland. Diabetes Ireland is a charity, and I work there as an advocacy and research manager. So hello, everybody. Thank you very much for having me, Tino.
Wow, this is amazing. So maybe people might need to say, okay, fine, what is really your connection with diabetes, besides your career background?
Besides my career, I think my connection with diabetes is just, it's there. It was there since I was 16 months old, because that's where and when I was diagnosed with diabetes. So I've been living with diabetes. I work in diabetes. I have many friends in diabetes world, and I'm absolutely passionate about diabetes as well. So diabetes is just a huge part of my life.
And I can definitely say that.
And then, what's the biggest change? Since then, my life started to improve, let's say, because of technology. I'm very, very biased when it comes to technology, because I do believe it changes lives and it makes life with diabetes so much easier. So I remember when I was diagnosed, my life was very schematic, and there was lots of routines that I had to make. So I had to eat 6 meals a day. I had to take 2 injections a day, 1 in the morning, 1 in the evening. I had to eat the same. I had to eat the same times of the meal, etc., etc. And it was very burdensome, especially for a child, because I just couldn't wake up when I wanted. I had to wake up every day at 7, get my injection, then wait 30 minutes, and then eat. And I always had to eat the same. So first huge change was when I started to use insulin analogs, so fast-acting insulin that you could adapt to the carb content that you have in your meal. So that was a big change, because for the first time in my life, I could have eaten, for example, 3 sandwiches instead of 1 or 2 whenever I wanted. So if I was hungry, I could have eaten more, and I just had to adapt to insulin. Whereas if I wasn't hungry, I didn't have to eat at all, and that was great. And then another game changer was insulin pump. My parents were very, very into technology and developments, and they were looking for many different new things, and it was still in Poland. And I think I'm probably one of the first persons in Poland who got insulin pump. My parents collected money for it, they got it, they bought it. It was very expensive by the time. It's still very expensive, but at least now we have some reimbursements in different countries. So I started to use insulin pump therapy, and that was absolutely life-changing. Then a couple of years later, a couple of years ago, so when I was pregnant in 2016, I started to use CGM continuously, and that was another game changer. And since I'm using automated insulin delivery system, my life is just so much easier. It's just so much easier to live with diabetes if automated system makes decisions for you. So absolutely, technology was the biggest change from my perspective.
Wow. I'm just out of words. You speak with so much passion in it. With everything, the detail, everything about it, which is just something else. So, maybe, the audience might need to know, we need to know, to say, what made you want to work in the diabetes field? Come to think of it, you're a patient advocate, you're a researcher, you've been a patient, a diabetes educator, psychologist, you're a researcher, all these titles on one person.
Well, I won't say that was the plan, and it wasn't like that I was, born, I got diagnosed with diabetes, and since then I was sure that I will work in diabetes field. Not at all. I was actually, when I was a child and when I was a teenager, I didn't really like to be involved in all this diabetes related stuff. I was managing diabetes very well. I was very independent. I was doing my own stuff, but I remember my parents asked me if I would like to go for a diabetes camp for people with diabetes, and I said, well, why with people with diabetes? I have my own friends, so I want to go with them for a camp, and they had a skiing camp, and I was 12 when I went for a skiing camp to Austria, and it was an amazing experience, and I felt so empowered and confident that I can do it. Of course, I had to be educated. My parents had to agree to that. We had to consult it with my healthcare professionals, but I was always raised in this kind of perspective that I'm totally normal. I'm just a person who likes to do different things. I like, for example, skiing or snowboarding, or I like to play football, and I can do anything, and I just have to adapt diabetes in my own life, and I have to manage diabetes somehow to be safe and to live with it well. So yeah, there was no plan that I will work in diabetes. I wasn't too much focused on that, but then there were two events that probably gave me some kind of a structure and an idea and perspective. So first event was when I was invited as a patient advocate, as a patient representative to the European Parliament in Strasbourg as part of IDF celebrations for World Diabetes Day. And that was in 2008, sorry, so it was some time ago. And that was the first time I met a few people with diabetes, and it was very exciting to talk about diabetes with so many and with politicians, and it was really great experience. And in the meantime, I was finishing my master's degree in psychology. I was completing my master's, and I had to figure out what's my research question. And I was thinking, okay, what can I do? I wanted to become a sports psychologist. So my plan was different. I wanted to work in a team. I was very into sports. I was training, I trained football, blah, blah, blah. From the practical point of view, I just thought, okay, so what can I do to really conduct this master's? And I had this kind of perception and perspective that people with diabetes are not very into sports. So my master's was on attitudes of adolescents with diabetes in activities and sport-related activities. So that was my master's. In the meantime, I set up an organization, a little organization. It was like a foundation, educate people with diabetes, because there was a huge need, especially for adults, for parents. In Poland, at least, there was not really much space for peer support by the time. Yeah, I started to run workshops on very different topics, like type 1 diabetes and exercise, for example, or type 1 diabetes and adulthood, and type 1 diabetes and whatever, women's health, So I ran, I think, approximately 100 workshops. I was educating schools. In the meantime, I started to work as a psychologist in outpatient diabetes clinic. So it was all thanks to my doctor, who we cooperated a lot, and Professor Ewa Pańkowska, she was actually very supportive, and she was helping me to do the workshops. We had this kind of hard work behind it, and she employed me in her clinic in Institute of Mother and Child in Warsaw, and this is where I started to work as a psychologist. And the third event that gave me another direction was ISPAT Science School for Healthcare Professionals. I applied and I got there, and I learned about research and how to conduct research. And this is when I really realized that research is the way to go if you want to change anything. So yeah, three important events. From Poland, from Warsaw, I moved to Ireland. I worked in outpatient diabetes clinic in Ireland as a research data manager. Then I wasn't sure what to do, so I conducted a PhD on accessing insulin pump therapy in Ireland. And after that, I worked as a lecturer in epidemiology and public health. And yeah, and my life is now research and advocacy and working for people with diabetes as part of the charity. So yeah, I just run with the flow. So I follow it.
Like, I felt like everything was just connecting, one thing leading to the next. I mean, all this, they sort of like had to happen for you, and now you moved from Poland, now you're in Ireland. Wow. So like, what is like your job role like in the diabetes island? I mean, you have such a big post there. What is it like?
Well, work in Diabetes Island is extremely busy, and I wasn't really aware of that. I was a member of Diabetes Island because I think it's very important to support organizations that are trying to do something for the whole community. So yeah, I was a member of Diabetes Island. I supported Diabetes Island, but I really had no idea how much work is involved in that. So, but yeah, I've been working there since I'm in Diabetes Island since July 2021, and I'm still learning, I have to say. But the big part of my job is, first of all, I would say the biggest is advocacy. So advocacy on all levels. So communication with people living with diabetes, leading Diabetes Island advocacy group, meeting with politicians, preparing pre-budget submissions and big documents, preparing big reports, conducting studies as well, because I'm a researcher, being involved in Diabetes Island Research Alliance, so I oversee that somehow. So research and advocacy, they are all very combined. But then there is a third thing that is not really in my title, but I do that. I'm a psychologist, so I also run workshops for people living with diabetes, for parents of children with diabetes. I do organize with my whole team, which I would like to say hi to. We organize conferences for healthcare professionals. We organize webinars, seminars for people living with diabetes, conferences for people with diabetes. So there's so much work, and we are just a small, really small team. There's only a few of us, really. Yeah, but this is how it is. But it's very, very rewarding job in terms of satisfaction that it gives you.
Wow, that thing, I mean, it's just amazing. Like everything. To say, yes, your job roles, there's like you have so much to do, but you also have to step out, like to say, okay, fine, you are also a psychologist by profession. So like, I don't know, like when you're teaching people, like what is it like, how can people living with diabetes get to like support others, like who are having like mental health issues? How do they handle that? How can people living with diabetes support others on mental health issues?
So there are different types of mental health issues, and mental health is overall a very, very big thing, and you don't have to have diabetes to develop any mental health issue. That's the fact. Because it depends on the circumstances, on your, let's say, how were you raised, your family situation, everything. But people with diabetes are at higher risk of developing mental health related issues. So, for example, there's higher risk of developing depression, eating disorders and disordered eating, anxiety. It is all there. Why is that? Because living with diabetes can be very demanding. It is 24/7. There's no break. And I do think that diabetes is one of a few really conditions, or maybe even only one, that demands from you so many medical decisions to make each day, every day. All day, every day, you have to make some kind of a medical decision. You have to inject your insulin, you have to decide how much insulin you have to check your blood glucose level, you have to check your CGM or whatever, you have to insert a needle into your body, and you do it every day on a daily basis, and you're at constant risk of having hyperglycemia, hypoglycemia, etc. So the fact of having diabetes is somehow burdensome. Then the treatment itself can be burdensome. Then whole associated risks related to diabetes complications, for example. Then all socioeconomic factors. So, for example, the cost that you have to, the money that you have to pay for your treatment if you have to. For example, being somehow judged or stigmatized in your society, what also happens, that is also a part of an issue. It can all build up onto, helping you to develop any kind of mental health issue. So how peers with diabetes could help, because that was the question. I think be there, share their stories. I think it's extremely important to hear and to listen. For example, if I had a very difficult situation, let's say I had a diabetes burnout, I think I would like to hear from somebody who experienced the same thing. How did they go through that? What helped them? And I think that sharing your own perspectives and sharing your experiences might be absolutely beneficial. And social media are very, very helpful in terms of helping people together to discuss things, like DDoc, for example. I think it's absolutely fantastic because it shows so many great initiatives by people living with diabetes, and there is a kind of a platform of sharing what's good, what's bad, what can be better, what can you do, how can you improve, and you're just learning from each other. So that's something that is really, really important. But just to mention, if there is any mental health disorder or condition, sometimes just the peer support cannot help. Mental health, mental illness is like normal illness. Sometimes you need to have your treatment, you have to have your medicines, you have to have you have to see a healthcare professional that will help you and advise you, because mental health is health. So, so don't forget about it. And if you struggle, and if anyone feels that they are burned out or very distressed when it comes to diabetes, because diabetes distress is a part of the problem, then really seeing a psychologist, even talking to your diabetes team or looking for help might be really, really helpful and beneficial, and you should be doing that, although there is still some stigma around that, unfortunately.
Wow. I mean, I could just say, wow, this is everything. The detail that he had to share, I mean, not so many people know this, because, I mean, people, I mean, I'll get over it. They don't know that they need help. And if you need help, like, it's important, like, to go to the professions, like, from people who have actually studied under that area. I mean, people have actually to go to school for it, so that they can actually help people in a professional way. So, I mean, people should really consider to do these things, because, I mean, mental health, okay, it's to everybody else. Mental health is health, like just like you said, which is great. So now considering, maybe the next question will be, we say that like now the diabetes community is growing, so many people are getting involved, and there are so many hashtags that they are using, and currently people, they say there's nothing about us without us. And now we are talking of the patient value, I mean the value that patients brings to the table. Do you like feel like, or do you think from your perspective to say patient advocates, they have like a certain value that they bring that nobody else can bring to the table? Like, what do you think about that?
Yeah, absolutely. Yeah, patient experience and this kind of insider knowledge, I think it's very, very relevant, and it's extremely important. And I'm absolutely delighted to see that people with diabetes advocates, are now the part of this community of researchers, of healthcare professionals. There are also many people who have and live with diabetes themselves, and are healthcare professionals and are the parts of diabetes teams, etc. And I think it's absolutely great, because it wasn't like that. It was usually historically, when you were diagnosed with diabetes, when you had your diabetes team, when you had your doctor, you were usually told what to do. And that's usually what happens when you go to see a doctor. Doctor tells you, you got to do this, you got to do that. But because diabetes is so complex, and because it affects 24 hours of your day, and because you are actually the one who makes these medical decisions every day, up to 40, 50, 60 medical decisions a day, and you only see your diabetes team, your healthcare professionals, if you're lucky, and if you're in, let's say Europe or United States, you see your diabetes team every 3 months, you have your appointment, you have access to your dietitian, you have access to your psychologist. That's in an ideal scenario. But many people do not have that worldwide. So people are on their own, and that's why it is extremely important to let them speak, let them talk, let them share what they find is, for example, difficult, or what would they want. So that's why research is very helpful, because researching people's experiences, for example, that's one way. But the other way is to be a part of the group and be the part of the stakeholder group. So that's why, for example, I love ISPAD. ISPAD is excellent because it was initiated by physicians, but then they wanted to have many other perspectives. So they included diabetes nurse specialists, they included psychologists, they included dietitians, And now they're opening up to patient advocates as well, because they should be at the table. So I think it's great, and it's changing, and it's definitely taking the positive direction now, and I think patient will have a lot more to say in the coming years as well.
Wow, thank you so much, and even for bringing this subject. I mean, a big shout out to ISPAD for these initiatives to welcome patient advocates. I mean, because it's always been like that, and now people, they'll also have to get the opportunity to attend and to say something that should be considered. Because, I mean, yes, there's nothing about us without us. I mean, we can say that. Now, we will move on to the next juncture. And I think, Mao, this is now relates. We need your opinion, your expert opinions, like to say, okay, fine. I mean, can you try, like, briefly explain to us, to say, how does diabetes distress? I mean, because I've attended sessions where you once talked about this. Now we are talking about it on this podcast to say, how does diabetes distress affect people living with diabetes?
How does it affect? So let's say we're talking about it, we live with diabetes 24/7, we have all these, decisions to make, we're on our own, we have to make those decisions. Then we see, for example, our diabetes team, and we are not very lucky to see empathetic, let's say, healthcare professionals. Anyways, we are being judged, for example. Yeah, so, oh, what have you done a week ago that you have such a high glucose level? Or what did you do that your HbA1c is so high? So you're coming and you're being judged. And this is an experience for many, unfortunately. It is changing because we are highlighting it, and it's great. Healthcare professionals should be part of your team, not someone who is judging you. That's the case. But I don't want to assess diabetes distress with this only, but what is happening with diabetes distress is that if you pay too much attention to diabetes, if it's associated with all those negative thoughts, it puts you in a very negative space. So if for example, everything that you do related to diabetes is distressing you, and you see your high glucose level and you're getting nervous, and it's an outcome of many different reasons. It's from your parents' reaction if you were diagnosed as a child. It's from healthcare diabetes team reactions as well. You feel bad when you have your high glucose levels. You blame yourself. Oh my God, what have I done? I don't want to do that. So it's a long and complex process, but distress can happen in parents of children with diabetes. It can happen in anyone with diabetes. Anyone can experience it at some stage of their lives, because it's just the burden that you experience as part of your diabetes management. The thing with distress is that when you're distressed, you're at continuous challenge, and you might develop as well diabetes burnout, because if you're distressed for too long, you feel bad, and then you just forget about diabetes. You're just so pissed off with diabetes, you just stop doing your care. And that's what is very, very dangerous, because this is when diabetes and all the risk associated with diabetes can hit you. So there are two sides of the story when it comes to diabetes distress. You might be distressed if you have mental health challenge already, if you're depressed and if your well-being is not good overall, or if you try to be perfect. And what is happening currently, and what I see and what I'm a bit worried about, is that even on social media, even within the teams, we are continuously talking about your fantastic blood glucose levels, about your time in range, how great it should be. Oh, 100% your time in range. And it builds up on this kind of need to be perfect when it comes to diabetes. Not only that, but also the fact that we want to avoid complications. Of course, we don't want to have high glucose levels, low blood glucose levels, and we're just trying to be perfect. And when you try to be perfect, perfectionism doesn't help. And it's a big factor when it comes to diabetes distress, so that's why I'm highlighting it. Because if you're too perfect for too long, you can easily burn out, because it requires so much hard work to have your perfect blood glucose values that it just doesn't make sense. So the ideal scenario is that you just live with your diabetes, you make your decisions, you're not getting emotional when you have high glucose level or low glucose level. This is just an information. You treat it as a, like, say, temperature check. If you're too high, you take your medicine, it will get better. If you're too low, you eat your medicine, you'll get better. That's it. No emotions, just stay away from emotions. And that's what I always say to parents, because sometimes their negative emotions can affect their children's diabetes distress. Because if my mom is continuously worried, and if she's, oh no, you have 20 millimoles, oh my God, what happened? Why did you have that? Blah, blah, blah. The next thing I will do, I won't tell her what my blood sugar is, or I will just tell, no, it's fine, although it's very bad. So that's what happens, and that's what making people dislike diabetes, if they assess all these negative emotions with that. And that's how diabetes distress works, and how it can be dangerous.
Wow. I don't know. I mean, I don't know. Like, this information is incredible. Everything that you're sharing right now, I mean, you're actually assisting me, helping me, because I've never gone to a psychologist for help. Maybe I didn't know I needed it, but yeah, this will be helpful, and especially to the audience that are going to watch this in the years to come, tomorrow, whatever the day they will watch. This one will be it will be there forever. So yeah, I mean, thank you so much for that great detail. I mean, going to depth to speak about this. So I don't know if there are sort of like, I mean, for people, if they go to psychologists, is there like sort of like a correctional measures that people can be subscribed, that people can look up to?
That's a very difficult question, and it depends on the place that you live, where are you from, and what offer do you have as a, for example, as a country, people living with diabetes. Because again, ISPAD is great. I really like it because it's really strong when it comes to advocacy for good quality of care. And pediatric care, thanks to ISPAD, not only thanks to ISPAD, but to many dedicated healthcare professionals, is leading the way. Is leading the way when it comes to technology, is leading the way when it comes to psychology. So for example, what is the recommendation? The recommendation is that every multidisciplinary team should have psychologists as part of the team. And why is that? And in an ideal scenario, if you're newly diagnosed with diabetes, diagnosis can really be very emotional for the whole family. It's very difficult. It is, some people really experience some kind of like for example, parents can experience a situation like they think their child is dying. The child was healthy and now is not healthy anymore. The grief, oh yes, grief, that was the word that I missed. Very negative emotions. And in an ideal scenario, if you can speak to a psychologist who will tell you that, for example, yes, you have full rights to experience all these emotions. It will be hard, but it will get better. You can ask any question related to mental health. You can just cry with this person if you want to and if you need to. This is how you are getting aware that mental health is the part of diabetes care. So if you don't have psychologists as part of diabetes team, and if you are not aware that somebody exists like that to help you with your mental part of things, then you think, if somebody tells you, your doctor, and it's good if your doctor will tell you, oh, listen, I see that you're struggling, maybe you would like to see a psychologist or psychiatrist. Then you think, oh my God, is it so wrong with me? I'm so bad with my mental health. And then you have this kind of stigma because you feel that it must be very bad if you're being advised to go to see a psychologist, etc. So again, in an ideal scenario, all diabetes teams should have psychologists. Psychologists should be a part of normal day-to-day assessment, should be a part of, for example, annual screening. You should be screened for your, I don't know, treatment satisfaction or difficulties in diabetes or diabetes distress or whatever. And if something goes wrong, then you're going to talk to a psychologist. And if something goes wrong really, really bad, then you might be referred to see a psychiatrist, or you got to start, your medical treatment if that's the case. So what is there? Again, it depends on the country, it depends on the health service, and it depends whether there is a psychologist in multidisciplinary diabetes team, because it's not always the case. And in adult services, it's not that common that this access to mental health specialists exists, unfortunately.
Oh, thank you so much. I mean, having someone like with diverse professional careers, like you have so many titles, you have focused and you have done so much, and you've done so many things in the diabetes community besides being a patient living with diabetes yourself. So now I think maybe we could jump on to the next. Maybe this one will be the next or the last section of our podcast to say, how do the rates of diabetes in Ireland compare to the rates of diabetes in your home country, like Poland?
The rates of diabetes and the prevalence and incidence, both in Poland and both in Ireland, we have the same issue, so we don't have diabetes registries. So we really don't know what the rates are. So we can only guess. But based on data from individual clinics or data, for example, prescription databases or whatever, we have some kind of an impression of what are the rates of diabetes. So incidence is kind of similar. In Europe, incidence is kind of similar, with the highest incidence rates, as far as I remember, in Finland. Poland and Ireland, when it comes to rates, would be kind of similar. It's just Poland is much bigger country than Ireland. So when it comes to the burden, for example, to the health system, etc., it might be bigger in Poland.
Thank you so much. That is really. But is there any issue, like, to say with access to insulin, CGM, between those two countries?
Yeah, these two countries have very different health systems, and that's how people access things very differently. So starting from the fact that in Poland you have to co-pay for your prescription. You have to pay some part of your prescription for insulin. That's the difference. In Ireland, there is a long-term illness scheme that allows you to have all your medical devices or diabetes-related medicines reimbursed, which is absolutely fantastic. That's great. When I came to Ireland and I realized I don't have to pay for my medicines, it was a big change. But what is happening is that access to technology is not great in Ireland, and that was actually the topic of my PhD. Why people are not using technology, although they have it for free. And that's very complex. And it shows also the differences between Ireland and Poland. So, for example, in Ireland, the uptake of technology is very small because there are not too many endocrinologists across the country interested in diabetes. There is, for example, a difference in Poland. We have diabetologists who are trained in a specialization diabetology, and in Ireland you have specialization endocrinology. So if you're, for example, if your endocrinologist is more interested in thyroid function and less interested in diabetes, then you might not be offered the best available care because this person is just not interested. Whereas diabetologists should know exactly what is happening in diabetes, what are the new things, what are the medicines. So maybe that's the difference. There's different approach to education. In Ireland, they want to provide structured education because they look at what is happening in the UK, and in the UK there is a DAPHNE program, so dose adjustment for normal eating, and it's great because many people can get educated. In Poland, we have no structured education programs. We just educate on the go. Yeah, mental health would be similar. So access to psychologists will be better in pediatric care, but not very good in adult care. And when it comes to reimbursement, yeah, in Poland, everything is reimbursed for people under 26, but if you're over 26, you have to pay for everything. So you have to pay for insulin pumps. You have it partially reimbursed, but you still have to pay your sensors, your infusion sets. Now they decided that sensors might be reimbursed in Poland. Freestyle Libre might be reimbursed in Poland. That's great. In Ireland, for example, we don't have reimbursement for flash glucose system, so we don't have reimbursement for Libre. So it's very different. There are different things because health systems are very different, and I can't say which one is better. I just can't say. They're very different factors.
Wow, thank you so much for, having so much like information to do like sort of like a contrast to say both what is happening in these two countries and just everything, and you could use it to your advantage to say, hey, I would choose to be there, I would choose to say there if I can, make a choice. That's really great. So like, I don't know, like if you could, how would you like encourage others to advocate for access to these devices, especially in the developing nations, like from Africa? How would you like, maybe, there must have been a great fight to have these things in your countries.
Yeah, so I think what you do and what the organizations and people who are first, raising the awareness, educating, talking about diabetes. I think there are still many issues in for example, in African countries with also the stigma around diabetes. So fighting the stigma is a very, very big thing. Sharing your story, being there for people, that's absolutely great. But then when it comes to practical advocacy, you have to talk to decision makers, and decision makers are usually politicians who are deciding, okay, where this money that I have, this money pot, which is not huge, where will I invest and why? So that's why research is extremely important for any kind of decision about the funding or reimbursement, because it shows you, okay, this improves the outcomes, this improves HbA1c, this is better, and this makes people living here safer. So this is why we should invest, and invest now versus investing in diabetes complications and paying loads of money on diabetes complications. So always economic evaluations, they always work. Research is very helpful. But just highlighting the issues, saying, talking to people, listen, I see that this doesn't work. I see other people have access to it. Why we don't have access to it? Why we can't have, for example, a cheap insulin pump, not very expensive, because what's the part of the problem is that all the devices that we have, they're actually quite expensive, and they're expensive. So, so for example, richer countries can reimburse them because they just have more money. But if you have a poorer country, then how the decision can be made to, for example, reimburse insulin pumps or CGMs, whereas it's tricky to get, you know, test strips. So an insulin and fast-acting insulin. So yeah, you have to choose your battles. You have to decide what's the most important, what would be the most beneficial for the whole community, and then just talk and push and push and say and push, use evidence, use data, collaborate with others, and raise the awareness. Because if people are not aware of existing devices or existing insulins or how their lives can be changed, then they won't fight for that, because they wouldn't be aware what to fight for. And then talk to healthcare professionals, because healthcare professionals might have a really, really strong voice in this fight. So collaboration is always the key.
Wow, you're amazing.
Oh,
Thank you so much.
Sorry,
With all these expert opinions, I mean, sharing from experience, the things that you've seen, things that really work, things that we can really use to make sure that we achieve some of these things, we could have them. I mean, thank you so much for that emphasis, collaboration, speak with the people that have relevance, people that can make things happen to see to the realization of these things. Now, this one will be our last question. So, I don't know, only have one device that can help increase the outcomes of diabetes for people living with diabetes, between a CGM or a pump. What would you like advocate for, and why would you choose that device between a pump and a CGM?
So, if you asked me for my personal opinion, what if I had to choose personally, I think I would choose insulin pump, because I really like the way how more flexibility I could have when I'm using a pump, and it gives me, you know, opportunity just to click a few buttons to inject insulin, But this is my personal opinion. And data and research suggests that the outcomes when it comes to HbA1c, the outcomes when it comes to patient-related outcomes, so for example, quality of life, when you compare insulin pump versus CGM is better. So I think if I had to choose for the whole communities, I would see people using continuous information about their data. It could be flash glucose monitor, it could be continuous glucose monitor, but you have to have information about what is happening with your glucose values so you can make the informed decisions. But the ideal thing, in my opinion, is automated insulin delivery. So combined device. And this also what data shows, that if you have your insulin pump that uses it's using information from continuous glucose monitoring system, and there is algorithm that uses this information and then informs insulin delivery, this is the way to go, because it takes so much of a burden from you. For any type of technology, education is essential, and sometimes I think that we forget about education, because you have to know what to do with this data. You can have your data, they can help you survive, but you have to know what's important. But yeah, when it comes to CGM, I wasn't the biggest fan of it in the beginning. It was kind of overwhelming, because now you're very overwhelmed with this data that are coming, and before that you didn't have to do that and be continuously on top. But I always say that it's like, you know, you're entering the room and you have your dark room, let's say, and you turn on the light for a second, and then you turn on the lights after 2 hours, and then you turn on the lights for a second after 6 hours, whatever. This is blood glucose testing, finger pricking. You just have one information, you can just spot a few things, and then you have to be, you know, blinded and still in the dark. Whereas if you have your CGM, you just turn on the lights and you can see everything. You can spot this, you can spot that. You see the differences, you see the changes. You know where you're coming from. I played tennis recently, and I just thought, okay, if you see the ball and the ball is here, you only see the ball. But if you see where is it coming from, how fast it's coming, and whether it's going down or whether it's going up, you know how to shoot. So that's what CGM does, and it really helps you. It really helps you make much better decisions and saves you and protects you from hypoglycemia. So yeah, technology is amazing.
Wow, thank you so much for that brilliant scenario that you had to put it. I mean, to make sure like people really understand what you're talking about. To say, hey, we need the light that is continuous so that you know to say, okay, if there's an enemy coming, you know where the enemy is coming from. Unlike when you're just having to put on the lights, you just see someone there, what is happening? So yeah, I mean, that's really impactful. So thank you so much. I cannot thank you enough. Thank you, I mean, for being part of this podcast. And I don't know if you have any last words to the audience.
First of all, thank you so much, Tino, for having me. And I really admire all your hard work. And I also really admire all the people, our advocates who are, using their free time. They're really using their opportunities, their, Facebooks, their Instagram, everything to make other people's lives easier and better, and they share and they respond to all the questions, and they are extremely amazing peer support for people living with diabetes. So so thanks everybody for that. I think you're doing a fantastic job. And yeah, what I also would like to just highlight, it's just we are all in it. It's not one thing that I see sometimes is we are patients, we are people living with diabetes versus healthcare professionals. No, we shouldn't be versus, we should be all together. We should collaborate, we should be here, and we should share and collaborate and inspire each other. So that's why it's fantastic that we have DDoC at ISPAT, that we have DDoC at many different conferences, that healthcare professionals are more open for discussions as well, and I think this is really the way to go. So yeah, so good luck. I'm delighted to see that this is happening, and all of you are part of it. So thanks a lot, Tino.
Wow, thank you. I mean, I think like this goes along with my motto to say, let's get involved, let's come together, and let's get engaged and come up together to create the change that we need. We are in this together. Healthcare professionals, researchers, people living with diabetes, because this is why this is being done. So let's be in this room together and make the change that we need. So yeah, thank you so much. You were amazing. So thank you.
Ciao.
Maybe Dr. Kate might need to say hi to some people that are really special in her life. So over to you.
Yeah, so
Wow, that is so great. I mean, it's always good to give a shout out. I mean, people feel like, wow, I've been mentioned on a video, and they'll be so great. I mean, so thank you so much for being part of this podcast and to so many things that we are going to do together to collaborate, network. I mean, that's a great thing. So because we're in this together. So yeah, thank you so much for being part of this podcast once again.
yeah, so thank you very much again. Happy birthday, Hannah. She has birthday in 3 days.
I'll get this podcast out soon. So yeah, thank you so much. Shukran Aila Aistiaiko. Thank you for watching. Thank you for listening. It's the Diabetic Mogul signing out in the UAE. Shukran. Shukran.